Effectiveness of Diabetes Self-Management Education on Health Outcomes, a case study by Carrie. Our case study includes an African-American woman, 45 years old, with a recent history of type 2 diabetes, fasting, blood sugars are high, and her A1C is very much above target. She's got poor glycemic control. She does self-report some exercise and diet modifications. And she's definitely an at-risk population group. African American women are twice as likely to die from diabetes compared to Caucasians. And 12% of African American women are diagnosed versus 7.5% of Caucasian women. Obesity and the curvy figure are appreciated as the norm, and there's less of a focus on being slim compared to Caucasian or mainstream culture. Emphasis of education on weight maintenance rather than weight loss. In other words, the prevention of further weight gain is also a different approach that's effective with this group. Small amounts of weight loss do not measurably or significantly reduce the A1C value. And then trends in dieting with the yo-yo effect often result, as we know, in weight gain in the long term. So if we can prevent the extra pounds, then that will significantly decrease their risk of cardiovascular disease. And then also social functions such as church, religious gatherings can be a difficult setting to cut back or monitor their disease. So considering what we do know about this population, what is the best approach? The purpose of this study was to examine the effectiveness of diabetes self-management education. Do African American women who received the DSME have decreased hemoglobin A1C, better glycemic control, and decreased risk for cardiovascular disease compared to patients who did not receive support or education to manage their disease? So the first article is a systematic review. 7 of the 13 of them are randomized control trials. This review looked at physical activity in the African American woman population. It does note that there is a higher incidence of obesity at 50%, which is pretty high. This population group is also more likely to be inactive. And that also noted that interventions that involve church and social support are more effective to achieve better health outcomes of diet and physical activity and adopting healthier behaviors. And conversely, a lack of social support, increased responsibilities, unsafe neighborhoods to even take a walk were all barriers to their physical activity. And the research concluded that the interventions led to increase in physical activity in African American women. The next article included 16 randomized controlled trials, and it looked at culturally tailored interventions for the African American communities dealing with type 2 diabetes. 6 of those 15 randomized controlled trials did report significant difference in the A1C levels with a significant p-value. They also tested diabetes knowledge as an indicator of success. And 5 studies, when they compared to control, led to increased glycemic control. 11 of 16 of those articles that used cultural interventions that were performed or supported by members of the community, which included dance instructors, church advisors, YMCA instructors, diabetes educators, showed significant decrease in the A1C at 8 months, 12 weeks, and at 6 months. So when they had persons inside their community that they trusted more than a healthcare provider, the interventions were a lot more significant and the results were a lot more significant. The studies all were conducted in community locations like community centers, churches, parks, in underserved neighborhoods. They found that the more cultural interventions that were used, the more significant the results. And it's not surprising that African Americans prefer to see clinicians or utilize a coach that matches their ethnicity. And this intervention also showed a reduction in A1C. And African Americans tend to trust community health workers to promote health education as the persons within their community understand their barriers and offer social support for diabetes management. The third systemic review that was brought in identified the barriers to African Americans living with type 2 diabetes in urban or inner city. Barriers they identified were at the individual, community, and health system levels, including crime, food security, safety, access, education, and they adopted a person-centered approach, used lots of empowerment, and setting realistic, individualized goals that are attainable. The value in this study, or the strength, was that it was a mixed study of both quantitative and qualitative, using descriptive studies and to identify barriers and the role of support and education on positive health outcomes. Limitations of this study: it was self-identified that no statistics were used. It was more of a narrative approach, so no causal relationships could be determined. But it did bring up a lot of good research that, lends to future research. They did also use theories of the socioecological model, behavioral model, and evidence-based model. The fourth article studied the direct effects of the intervention of this case study of the diabetes self-management education on the outcomes for type 2 diabetes. It showed that it increased knowledge and maintenance with diet, exercise, wound care, and glucose monitoring, and medication. There's an overall positive lifestyle change, such as improved diet, increased duration of exercise, diminished alcohol and tobacco use. There are some mixed results with the A1C levels in this systematic review, but it did show ultimately that the effectiveness of the diabetes self-management education related to support systems and diabetic educators. The fifth article was a very strong systemic review with 13 randomized control trials, and it brought up individualized interventions with an educational focus on empowering and using patient-defined goal settings to improve self-efficacy, to manage their diabetes. Talked about motivational interviewing as an intervention, and to build rapport, to understand patient preferences and their barriers. It discussed peer support, group-based interventions, and it also highlighted the duration of contact, or the length of the program directly was related to the success. And it also did show a decrease in A1C in a majority of the RCTs that were included in this review. So if we want to apply the evidence into this case study, it's really important to know your patient and their individual barriers to health maintenance and their care. Consider the audience and their level of medical literacy. Assess her baseline knowledge of her disease. What are her support systems and how can we integrate them into her care plan and utilize that social support that she has? Focus on weight maintenance versus weight loss. Establish trust and rapport is got to be number one, with frequent check-ins at first in a long-term relationship. And start with very small patient-driven goals at first. In my clinical expertise, I've noticed that there's a big stigma with type 2 diabetes. It's really overwhelming and exhausting to check blood sugars multiple times a day. Patients have a really hard time seeing the long-term health consequences. It's a very complex disease to manage, and patients are needing a lot of support. And there's also a strong familial and genetic component. In summary, we have to take Mary's preferences and her values into account. We might assign her to an African American healthcare provider or a diabetes educator that she trusts. We would research community programs such as the YMCA, church, neighborhood health programs. We would assess her individual community and healthcare level barriers. Use a patient-centered approach to help Mary come up with very attainable short-term goals. We're going to do frequent check-ins and follow-ups. We're going to introduce her to a support group so she doesn't feel like she's alone. We're going to focus on weight maintenance so that she doesn't put on a lot of extra weight, which will definitely lessen her risk for cardiovascular disease. And we also might explore medications other than insulin to prevent weight gain, and slowly decreasing that A1C over time will decrease her cardiovascular risk.